Okay, thank you. So I'm starting with the topic peripartum cardiomyopathy. A lot of the discussion was done in the last couple of the days. So I'm going to try to sum up my presentation within 10 minutes. It is you all aware about that it's a idiopathic condition which is present with the systolic ventricular systolic dysfunction toward the end of the pregnancy or in the month following, where there is no other cause of the heart failure is identified. Mostly the 44% are diagnosed in the postpartum period, and next one to the is 27% within a 6 month of, and 8 about it's. No, my topic was changed and I updated my topic and it was not printed. It must be a printing mistake. So at 23% is at the time of the delivery and the remaining 6% during the pregnancy. So we are facing a lot of the challenges to cope up with disease of the during the pregnancy, cardiac diseases, even in cardiomyopathy. Once if we're discussing about the incidence, it is raised, and other days we are not having the proper data which know that what is the incidence, proper incidence, and it is variable in the different countries. Come to the diagnosis, it is actually a diagnosis of exclusion. We are not having the particular, we are mostly rely on the clinical findings and on the echocardiographic finding and the diagnosis and treatments. Usually there is not a specific treatment. We are dealing with the two lives, a mother and the baby. And in lack of data, even in the developed countries, the prevalence of the cardiac disease and the incidence regarding the peripartum cardiomyopathy is not recorded properly. It is the complex phenomena. It's a heart failure due to the pericardium, PPCM is the complex phenomena, which is mostly must be dealt with the specialized center, which dealing with the patient with the heart disease in pregnancy. But we all aware that we are not having a such kind of a specialized center where we can deal the patients of the having the cardiac disease during pregnancy. And therapeutic intervention again is a challenge that we are dealing with the two lives, and we have to give the treatment and for the mother, and we must think about the baby and we must think about the mother. And regarding the mortality and the morbidity, according to the WHO, it is increased at about 19 to 27% and extremely high, more than 40% risk of the morbidity and the mortality. It is depend upon the left ventricular ejection fraction and the NIA class 3 and the 4. These are the high prevalence or high incidence, or the mortality is more with these conditions. You all aware about this diagnostic criteria, the development of the heart disease, development of the heart failure in the last month, and the pregnancy for up to the 5 months, when there is no identifiable cause, and with supported by the echocardiographic finding as left ventricular and diastolic dimension. With these last two, the M mode fractional shortening less than 0.45 and left ventricular ejection fraction 0.45. This is a slide which is taken from the Euro Observational Research Program registry in 2019. You can see here there is a 739 women are enrolled in 49 countries worldwide. In European, it was 27%, and Africa, it was 29%, and Asia Pacific, it was 22%, and Middle East, it was 15%. These are highlighted here, the most of the incidents in the low income group, low income countries, and the very low income countries, rather than those who are the high income countries. These shows the geographical variation and the patient who are receiving the treatment during their pregnancy, and lot of the socio-economic concern. These are variation in the incidences. This is the incidence of the USA. It is 1 in 1,000 in 4,000 live birth. Another in the raised in the Africa and Asia, 1 in 1,000 live birth. And northern Nigeria, the incidence is higher at about 1 in 100 live birth. One study which was conducted in California, which shows that the peripartum cardiomyopathy, 23% of the maternal death are due to the cardiovascular disease. These are the variation of the incidence. You can see the higher the lower income group and lower income country, and the higher the incidence. And this incidence is increased over a time. Once you look at on the left side, there is the 8.5 per 10,000 live birth in 2004, and that is increased by the 11.8 per 10,000 live birth. This is the incidence of the USA. We are not having the particular incidence in our country, and this increase of the incidence is secondary to increased maternal age. Mostly the patients are, mostly the ladies are going to married in late. Another important thing is that they are getting married in earlier age, less than the 80 years. These both factors are the very important factor for the development of the cardiomyopathy. And the increase in the diagnostic modalities and increased multifetal pregnancies due to the increase of the availability of the assisted reproductive techniques and the increased prevalence of the hypertensive disease including preeclampsia and the eclampsia, and the comorbidities which are discussed is hypertension, obesities, and the diabetes. This is actually the, what is the pathophysiology? Actually, none of the pathophysiology is described. It is previously thought it is due to the myocarditis. This hypothesis is changed. There is another hypothesis, newer hypothesis is coming, that is two-hit model, which is the vascular insult caused by antivascular or hormonal effects on the pregnancy in early postpartum period, and induces peripartum cardiomyopathy in those women who are genetic predisposition. This is hypothesis is given, it is known as the two-hit model, and once genetic predisposition, the most important, the TTN gene, which encodes the titin as an essential component of the sarcomere, were detected. And this is the, when it is variant is present, the left ventricular ejection fraction lower at the 12-month follow-up. And the prolactin, which in the pregnancy play an important role. As you can see here, the hormone prolactin, which is released from the pituitary gland, it is released and it is cleaved by the cathepsin D into the 16 kHa, and it lead to the angiogenesis, it lead to the leaking of the capillaries and activation of the mRNA 146A. This is the pathogenesis, an important one, which lead to the peripartum cardiomyopathy. And by this, to understand this mechanism, the bromocriptine therapy is used to treat the peripartum cardiomyopathy. In shorter or long term, it is very effective. And the third one is the placental angiogenic factor. During late gestation, placenta secrete the soluble FMS like tyrosine kinase and anti-angiogenic protein. This is an important mechanism behind the preeclampsia and hypertensive disease of the pregnancy that contribute to the development of the peripartum cardiomyopathy later on. These are the sum up of the proposed pathophysiology and the risk factors. You all aware about the risk factors, so I'm not going in much detail, just emerging risk factor as the genetic and the increased prevalence of the preeclampsia, obesity, and the other metabolic problems. Regarding the management option, beta blocker and the loop diuretic, even though they can lead to the intrauterine growth restriction, but we can give as compared to the drugs as ACE and ARB, which are not recommended during pregnancy. During delivery, the plan of delivery must be in the cardio-obstetric units and where the facility is available. And if patient is unstable, first priority is to stabilize the patient. Then the monitoring the fluid overload is important, because after a delivery there is the 500 ml of the blood which is circulated in the uteroplacental push back into the maternal circulation, which increase the preload. And coming to the after delivery, the heart failure treatment as bromocriptine, beta blocker, and the oral heart failure treatment along with the anticoagulation in those patients who are having the decreased LV function and ejection fraction less than the 35. Coming to the our studies, which is conducted at the Department of the Gynecology and the Cardiology, it is a single center studies. We try to cover up a lot of the topics, and this is done for this is the ongoing study. 3 years, up to 3 years, we are supposed to take this study for 5 years. The main objective of our study is to identify the incidence of the cardiomyopathy and the presence of the how patient present during the peripartum cardiomyopathy, risk factors, and the maternal and the fetal outcome. It is the prospective longitudinal ongoing study. Data is collected from the 3 years, January 2020 to December 2022, in the Department of the Gynae Ops and the Cardiology GMC Sakhar. We include the patient of 15 to 50 years of the age with those who made the criteria of the heart failure, late pregnancy prior to 1 month, and the up to 5 months, and those who are already having the peripartum cardiomyopathy in previous pregnancy are also included in the studies. This is about the how we calculate the data collection with the basic demographic and the clinical findings, and the later on go for the evaluation and the risk factor assessment, and the particularly the important one is the hypertensive disorder and the preeclampsia, and the pregnancy outcome is measured. The diagnosis is mostly depend on the clinical presentation and the echocardiographic finding and the X-rays which are available, because we are not having a lot of the facilities available to go for the other higher investigation. The outcome is measured in the discharge patient and the hospital mortality, and the follow-up of the patient is done up to the 6 months. The incidence, which is calculated per 1,000 live births, you can see here there's incidence from 2020 to 2022. In 2020, that was the time of the COVID. But you can, if you look at the incidence, it is remained unchanged in 2022 and 2021, because we reduced the admission of the gynecology and not going to reduce the admission of the obstetric. So the incidence remains same. Totally, the 119 cases are included, are registered, and the total delivery was 8,911, and the incidence is a 4.45 in the calculated for the total 4 years. This slide is included. You know that the inclusion criteria is 15 to 50 years. Particularly giving the importance, I put this slide because there is the 2 patients are before the age of the 15 years. And this is the mean age is the, in our study was 31, which is quite comparable with the other studies are present in the different part of the world. And you can see here the most of the patients are in the age of 31 to 40 years up to coming. You can see this between the age of 21 to 30 years. There is a 22.68% of the patient, and 2%, which are actually just for the interest I put here because our study is started from the 15 years. But unfortunately, I received the 2 patients before the age of the 15 year. One is at the age of the 14 year, one is at the age of 13 years. And this is a risk factor. Mostly the risk factor is the multiparity, and the age over the 30 years is 57%. And hypertension, severe preeclampsia, and eclampsia contributed the good number of the risk factors. These are the associated factors. Okay, I'll try to finish. Please give me some time. Diabetes mellitus and ischemic heart disease are well-known risk factors. These are the present in our studies. And the mostly patient present with a shortness of breath, up to the 65%, followed by 26% with the palpitation and the chest pain. See, same risk factors. These are the ECG findings and echo finding. Conclude kar दूं? I'm not going to discuss the delivery more.
Time नहीं है आपके पास.
Okay, जी. I want to discuss this slide. We are maternal death at about 17.64%, which is quite comparable, the fetal outcome. And the peripartum cardiomyopathy is a rare but a serious condition of unknown cause. Undiagnosed peripartum cardiomyopathy rapidly progress to life-threatening condition. PPCMP heart failure in peripartum period, its incidence and the prevalence is highly variable. Depending on the race, geographic region, incidence is highest in African and these races. Diagnosis requires higher awareness among the multidisciplinary patient care team. Its clinical outcome, it also diverts the complete recovery. It's recommended that it would be advisable to conduct a PPCM registry as there is no data related to PPCM incidence, prevalence, course and the outcome available for our country.